Hello viewers, good day to all of you. So, in this lecture, I am going to summarize the nerves of the upper limb. That is, I am going to summarize mainly the three nerves, that is, the median nerve, the ulnar nerve and the radial nerve. Because these three nerves only, they supply the majority of the structures of the upper limb. Most of the structures beyond the axilla, that is from the lower part of arm, forearm, intrinsic muscles of hand and the related joints, cutaneous innervation, everything is by these three terminal branches of the brachial nerves. And not only that, examination point of view, so any one of these nerves might be asked as an essay question, or a part of this nerve might be asked even as a short note. Okay. Now today we are going to just review the course, relations and the branches of, as I told you, the median nerve, the ulnar nerve and the radial nerve, followed by which we will be also discussing some aspects of the applied anatomy. Okay. So, we have seen the course, origin, course, relations and branches of these three nerves, bits and parts in the arm, in the forearm and the hand. Now, what we are going to do is, in this session, I am actually going to summarize everything so that as one single answer you can write any one of these nerves. So, to start with, as a thumb rule, we all know that the innervation of the upper limb is from the brachial plexus. So, any nerve you start, you should actually start from the brachial plexus. So, what I mean is, you need not completely describe the whole brachial plexus as such. That is the formation of the roots, formation of the branch, divisions, and then the cords, and then the branches. You need not do all those things. Just you should start writing from which cord and what is the root value of this nerve. So, before that, quickly, we all know that it is from the lower four cervical nerves and the first thoracic nerve, which forms the roots of the brachial plexus. C5-C6 unites to form the upper trunk, C7 as middle trunk, C8-T1 unites to form the lower trunk. Each trunk again divides into anterior and posterior divisions. Anterior division of upper trunk and middle trunk forms the lateral cord. Anterior division of lower trunk alone passes as the medial cord. Posterior division of all the three trunks unite to form the posterior cord. And they give so many branches, and the most important branches, that is from the medial cord you have the ulnar nerve, from the posterior cord you have the radial nerve, and the median nerve is a combination of or contribution from the medial cord as well as the lateral cord. Okay. So, first to start with, we are actually going to deal with the median nerve. So, median nerve is simply also called as the laborer's nerve. So, why do we call median nerve as the laborer's nerve? Because it mostly supplies the muscles of the flexor compartment of your forearm. Okay. So, I have already mentioned in my earlier sessions that the flexor muscles are more massive in the forearm as compared to the extensor muscles, because they work against the gravity. So, naturally they should have more power than the extensor muscles. Okay. And since this nerve supplies these muscles of the flexor compartment of the forearm, and especially in laborers, the action of these muscles are indispensable to perform various tasks. So, it is origin from the two roots, that is the medial root of median and the lateral root of median unites to form, and it actually occurs in front of the third part of the axillary artery. So, since it is a combination of both medial and lateral cord of brachial plexus, the root value naturally should be C5, C6, C7, C8 and T1. So, coming to the course of the median nerve, we will start from the axilla. So, it is actually present in front of the third part of the axillary artery, then what happens is it is present lateral to the axillary artery in the upper part of the arm. Then when the axillary artery continues down as the brachial artery beyond the lower border of the teres major, in the arm also to some extent it is present only lateral to the brachial artery. Okay. Now at the level of insertion of this muscle, the coracobrachialis, exactly at this place, what happens is the median nerve crosses the brachial artery from the lateral side to the medial side. So in the lower part of the arm, and of course it is going to enter into the cubital fossa, what happens is the median nerve is present medial to the brachial artery. Okay. Now in the cubital fossa, you all know the contents of the cubital fossa. So from lateral to medial or medial to lateral. Lateral to medial, it is tendon of biceps, brachial artery in between, and the median nerve, the most medial structure. Or from medial to lateral you go, it is the median nerve, brachial artery, and the tendon of biceps, and all these are again covered by the bicipital aponeurosis. So which is actually cut here for you to appreciate the structures in the cubital fossa. Okay. So it is deep to the bicipital aponeurosis and lying in front of the brachialis muscle. Okay. So as I told you, it is the medial most structure. Then how actually it enters into the forearm? So this muscle is again cut for you. It passes between the two heads of pronator teres. So the muscle is going to pass between the two heads of the pronator teres. And you are able to see here, this is actually the tendinous arch of the origin of flexor digitorum superficialis. Okay. So that is the tendinous origin of the flexor digitorum superficialis. Okay. Now here you are able to see the brachial artery dividing into the radial artery, which is somewhat superficial in its course, and that is the ulnar artery. So the ulnar artery is actually present medial to the median nerve. Okay. So now after passing between the two heads of the pronator teres, then it is present between the tendinous origin of flexor digitorum superficialis. That's what I told you. Then in the forearm, it is actually present between the flexor digitorum superficialis above and the flexor digitorum profundus below. Okay. So that means it is present between the superficial and deep group of flexor muscles in the front of the forearm. Then what happens is at the lower end of the forearm, that is 5 centimeters above the flexor retinaculum, it comes somewhat superficial and tries to lie between this palmaris longus tendon and the flexor carpi radialis tendon. Okay. So here you are able to see here. So at the lower part, immediately just above the flexor retinaculum, 5 centimeters above the flexor retinaculum, it becomes somewhat superficial, and it is present between the palmaris longus tendon and the flexor carpi radialis tendon. Then after which it is going to pass deep to the flexor retinaculum. So here it is actually situated within the carpal tunnel. Okay. So I am not discussing about the carpal tunnel here. We have already discussed well and much about the carpal tunnel in the previous classes. If you want, you can also mention the boundaries of the carpal tunnel in your answer if median nerve is asked as a separate essay question. Then once it emerges from the flexor retinaculum, so distal to the flexor retinaculum, the nerve immediately flattens and it divides into 5 or 6 branches. Okay. But basically it will divide into 2 rami, the lateral rami and the medial rami. Okay. So once it emerges from the flexor retinaculum, it enters the palm where the nerve flattens and immediately it divides into medial and lateral rami. Then from there on it is going to give branches. So we will actually discuss about the branches starting from the axilla. So the median nerve does not give any branches. in the axilla. Okay, so usually the median nerve does not supply any muscles or skin of the forearm. In the arm, it might give vascular branches to the blood vessels, and it is giving a branch to the pronator teres. So it supplies the pronator teres. Its main supply is in the forearm, the muscular branches, which is going to supply your flexor carpi radialis, palmaris longus, flexor digitorum superficialis, pronator teres. All these muscles it supplies. It also gives one more nerve, that is the deep branch of the median nerve, which is called as the anterior interosseous nerve. It is called as anterior interosseous nerve because it is present immediately in front of the interosseous membrane between the radius and ulna, and it is accompanied by the anterior interosseous artery. The anterior interosseous artery is again a branch from the common interosseous artery, which is actually a branch from the ulnar artery. Okay, so you are able to say ulnar artery giving common interosseous, which is again dividing into anterior and posterior interosseous artery. So the anterior interosseous nerve accompanies with the anterior interosseous artery. It is the deep branch of the median nerve, and naturally it is going to supply the deep flexors, mainly the flexor pollicis longus, the pronator quadratus, and the lateral half of flexor digitorum profundus. Okay, and finally that nerve will end by supplying the wrist joint. Next, what happens is, from the forearm, the nerve is actually going to enter the palm. From the forearm, what happens is, the nerve is going to actually enter the palm. So in the palm, it is going to give some branches. The first branch is actually called as the palmar cutaneous nerve. It is actually called as the palmar cutaneous branch of the median nerve. The palmar cutaneous branch of the median nerve gives before the median nerve enters deep to the flexor retinaculum. Okay, so it passes above the flexor retinaculum. So here, do you remember the structures passing superficial to the flexor retinaculum? So palmaris longus tendon, palmar cutaneous branch of median nerve, ulnar artery, ulnar nerve, tendon of flexor carpi ulnaris. These are all the structures passing superficial to the flexor retinaculum. Okay, so this palmar cutaneous branch of median nerve passes above the flexor retinaculum and supplies the skin over the central part of the palm and the skin over the thenar eminence. So central palmar skin and the skin over the thenar eminence. Okay, now branches we have seen, no branches in the axilla. In the forearm, it gives a branch to pronator teres. Then it gives branches to the most of the flexors of the forearm, and in the palm, it is going to give branches, mainly recurrent branch, muscular branches to the thenar muscles, then which are called as a recurrent branch, and then it is going to give digital branches, which is going to supply the lateral 3.5 digits. So thumb, index finger, middle finger, and the lateral half of the ring finger. So 3.5 digits it is going to supply. Okay. So here you are able to see the first branch, which is actually called as the recurrent branch. So this is actually called as a recurrent branch because it travels in the reverse direction. So it is this recurrent branch which will supply your thenar muscles. So abductor pollicis, flexor pollicis brevis, opponent's pollicis, abductor pollicis brevis, flexor pollicis brevis, and opponent's pollicis. So these muscles form the thenar eminence. So the median nerve will actually supply these muscles. Okay. Then, as I told you, it divides into a lateral ramus and a medial ramus. Okay. So the lateral ramus mainly supplies your thumb, the both sides of your thumb, and it also supplies your lateral side of index finger. Okay. So it supplies both sides of your thumb and lateral side of the index finger, and it also gives a branch to the first lumbrical muscle. Okay. So it also gives a branch to the first lumbrical muscle. Then you have the medial ramus. The medial ramus will give common palmar digital nerves. And this will again divide into proper palmar digital nerve to supply the adjacent sides of your index and the middle finger, middle and the ring finger. So thereby it totally supplies 1, 2, 3 and a half fingers. So that is from the medial ramus. Now this medial ramus also gives one more branch, that is to the second lumbrical muscle. So in the hand, the median nerve supplies your thenar muscles, then it also supplies the first and second lumbricals, and it is going to supply the digits, that is the lateral 3.5 digits. Now sometimes what happens is, in the hand there might also be a communication between this medial ramus of the median nerve and the ulnar nerve. Okay. So now we know that mainly what the median nerve supplies: muscles of the forearm, muscles of the thenar eminence, first and second lumbrical muscles, and lateral 3.5 digits, including the nail bed structures. So that is the dorsal part of the arm up to the middle phalanx. The median nerve supplies even the dorsal part of your digits. Okay. Now coming to the applied aspects. So the most common sites of injury in the axilla, it might take place. So naturally in the axilla, median nerve or sometimes directly to the brachial plexus injury can cause symptoms of median nerve. Then in the cubital fossa, supracondylar fractures of the humerus mainly can lead to compression of the nerve or compression of the brachial artery. Then in the wrist, then in the carpal tunnel. So mainly if the median nerve is affected in the region of axilla, pronating the arm, weakness in pronation, because pronator teres and pronator quadratus both are actually affected. Ulnar deviation of wrist is taking place. While you try to flex, there will be ulnar deviation due to the unopposed action of flexor carpi ulnaris and flexor digitorum profundus, because these two are actually innervated by the ulnar nerve. Then you have thenar muscles wasting. So you have loss of opposition to opponent's policies, then loss of flexion and weakness of abduction of thumb because of the abductor pollicis brevis and flexor pollicis brevis. It is all weakness because abduction is again taken care by the your dorsal interossei muscles. So not total abduction will not be lost, but weakness in abduction will be taking place. Okay. So in the axilla, these will be the symptoms. That means when the whole course of the nerve below the axilla, definitely it is affected. Ape thumb deformity naturally takes place. The thumb is actually adducted, extended and laterally rotated. So here you are able to see the various tests performed to test the integrity of the ulnar nerve. So most common one is the pronator teres syndrome in the forearm, when the nerve is actually compressed between the two heads of the pronator teres. Okay. So you have hyperesthesia and activity induced paresthesia. So sensations, pain sensations, mainly you have altered sensations you might be having. Then compression when it is passing through the tendinous arch of flexor digitorum superficialis, that can be tested by asking the patient to flex the middle finger against resistance. So if the flexor digitorum superficialis is damaged, then naturally what happens is he won't be able to flex his finger against the resistance. Pronator teres syndrome, again asking the patient to pronate against resistance. So you give some resistance and ask the person to, what you do is pronate. Then sometimes if it is actually compressed in the lower part of the arm or elbow by ligament of Struthers, so you ask the patient to flex your wrist against the resistance. Okay. Then this is pinch grip mainly to test whether the long flexors are again are actually innervated properly, integrity, especially the flexor pollicis longus and the flexor digitorum profundus muscles. So anterior interosseous nerve mainly to test this pinch grip. Okay. This is normal, adduction only should take place, but when there is a flexion, then it is actually anterior interosseous syndrome in the pinch grip. Okay. The next what you see here is when the nerve, as I told you, when it is compressed by the ligament of Struthers. So ligament of Struthers is actually a facial band thickening of the deep fascia extending from supratrochlear spur. Immediately above the trochlea you have a bony marking. From there, if it goes to the trochlea of the humerus, that is actually called as the ligament of Struthers. This is actually different from arcade of Struthers. Arcade of Struthers is where the ulnar nerve will get compressed. Okay. So due to supracondylar fractures in the cubital fossa or when it passes between the pronator teres, it might get compressed. Bicipital aponeurosis might actually compress the median nerve. Okay. So it might be due to ligament of Struthers when it passes between the two heads of pronator teres, or when the bicipital aponeurosis can compress it, or the tendinous arch of flexor digitorum superficialis might actually compress the median nerve. Sometimes there is a connection between the median nerve and the ulnar nerve in the forearm itself. This is actually called as Martin-Gruber connections. So definitely motor fibers pass between these two nerves. So in that case you should keep this in mind while diagnosing, because sometimes what happens is if there is such a connection, then naturally you should be very careful in diagnosing whether it is a median nerve injury or a ulnar nerve injury. So in the last slide itself you have seen of the anterior interosseous nerve syndrome, weakness of pinch grip. So which means the patient should have a very strong pinch grip. So you should adduct and hold a piece of paper in between. While trying to pull the paper, what happens is the fingers should not flex. It should be kept in a adducted and extended position. Then in the wrist, if it is affected, it might lead to ape thumb deformity, and palmar cutaneous branch, if involved, will lead to loss of sensation over the central palmar and thenar eminence. So carpal tunnel syndrome, this also we have discussed well and enough. So painful paresthesia and numbness over the lateral 3.5 digits, severe during early hours. So why actually during early hours is because at rest what happens is the inflamed material might get collected if it is a tenosynovitis or some fluid collection. So as day progresses, what happens is when you do some activities, the blood flow increases and naturally the inflammation might get reduced. So that is why it is actually resting pain and severe during early hours. So if this is compressed in the carpal tunnel, wasting of thenar muscles takes place and loss of sensations over the lateral 3.5 digits. So we will move on to the next nerve, that is the ulnar nerve. Okay. So here you are able to see the ulnar nerve here. It is also called as the musician's nerve. You know why it is actually called as the musician's nerve? Because it mainly supplies the intrinsic muscles of your hand, which is responsible for all the fine movements of your digits. So especially in playing a musical instrument or any skilled movements like painting, drawing, doing some craft work and all those things. So all these muscles are in the control of the ulnar nerve. So that is why it is actually called as the musician's nerve. So origin from the medial cord of brachial plexus. So medial cord is formed by the anterior division of the lower trunk C8 and T1. Sometimes what happens is it also receives fibers from C7. So that is why in some books you can see that C7 is given within the brackets apart from C8 and T1. Coming to the course of the ulnar nerve, in the arm it is actually, and in the axilla almost it is present medial to the axillary artery. Okay, and also it is present between the axillary artery and more medial structure, or the most medial structure will be the axillary nerve. So not only in the axillar arm, if you look at the ulnar nerve, throughout its course it is present along the medial border of the arm. Only for a short distance in the lower part of the arm, what happens is, first of all it is present medial to the brachial artery, then suddenly what happens is it pierces the medial intermuscular septum and passes behind. Okay, so here it passes posteriorly and it is lodged in a sulci, which is actually called as the nervi sulci ulnaris. Okay, so here once it is pierced the medial intermuscular septum, it is lying anterior to the medial head of triceps. Okay, then it is present in the sulcus between the olecranon process and the medial epicondyle in the nervi sulci ulnaris. Then in the forearm, so again it is present in the medial side of the forearm. It is present between the flexor carpi ulnaris and flexor digitorum profundus. So between the superficial and the deep group of flexor muscles. In the distal forearm, it becomes superficial and it is only covered by skin and fascia. So here you are able to see it is somewhat present in a deeper plane between the flexor carpi ulnaris and flexor digitorum profundus. In the lower part of the arm, what happens is it becomes superficial and definitely it passes above the flexor retinaculum along with the ulnar artery. Okay, so along with the ulnar artery passes superficial to flexor retinaculum and in the Guyon's canal. So again Guyon's canal we have described, so anyway I will repeat once again. So what happens is Guyon's canal, below it will be formed by the flexor retinaculum. Above, palmar carpal ligament will stretch across, thereby creating a tunnel like structure through which the ulnar nerve will pass. So more chances of compression of ulnar nerve in the Guyon's canal. So after that it immediately divides into superficial and deep branches. So that is it is actually immediately dividing into the superficial branch and of course the deep branch. The superficial terminal branch will supply one proper palmar digital nerve to the medial side of the little finger, one common palmar digital nerve which will again divide to supply the adjacent sides of the little finger and the ring finger. Okay, so thereby what happens is it supplies the medial 1.5 digits. Okay, so the superficial branch mainly supplies the medial 1.5 digits. The deep branch is actually not seen here. It passes deeper, piercing or passing between the hypothenar muscles. Then it will be present more on a deeper plane. I will come to this. So in the axilla and arm, again ulnar nerve does not give any branches in the axilla as well as in the arm. In the forearm, it gives muscular branches to the flexor carpi ulnaris and to the medial half of flexor digitorum profundus. So that is to the tendons of the little finger and half of the ring finger, flexor digitorum profundus. Then palmar cutaneous branch. So it will give a superficial branch. It is actually called as the palmar cutaneous branch. Even though it is called as cutaneous, it supplies palmaris brevis muscle. This palmaris brevis muscle is again a very, very vestigial muscle which is seen deep to the skin. Some few fibers you can come across, most of the time it is missed. It is helped to gather the skin over the hypothenar eminence. Not much of function is there. So it mainly supplies the skin over the hypothenar eminence, and then it supplies the palmaris brevis muscle. Okay, so in the forearm, medial 1.5 muscles it supplies flexor carpi ulnaris and medial flexor digitorum profundus. Superficial branch mainly, cutaneous branch mainly supplies the skin over the hypothenar eminence and the palmaris brevis. Then in the lower part of the forearm, it also gives a branch which is called as the dorsal branch of ulnar nerve. Okay, so just 5 centimeters above the wrist, it passes deep to the flexor carpi ulnaris and it is going to supply the dorsum of the hand, that is the medial 1.5 digits. Okay, so back of the arm, it supplies the medial 1.5 digits. Again, the same manner like how we saw on the palmar aspect, one proper palmar to the dorsum of the medial side of the little finger and one common palmar again dividing into the to supply the adjacent sides of the ring finger and the little finger, excluding the nail bed. The nail bed, even though it is supplied by the ulnar nerve, it is actually by the palmar digital nerves, not by the dorsal nerve. Okay, so that is what I told you. Except the nail bed, it supplies these structures. So superficial terminal branch, here we are able to see, which is actually supplying one proper palmar to the medial side of the little finger and common palmar again dividing into two proper palmar supplying the adjacent sides of the ring and the little finger. Coming to the deep terminal branch. So here we have seen the superficial branch, now you are able to see the deep terminal branch. This deep terminal branch alone again can be asked as a short note. So accompanies mainly the deep branch of ulnar artery and it is present passing between the two hypothenar muscles which are present in the more superficial plane, that is the abductor digiti minimi and the flexor digiti minimi. Okay, then it will pierce the opponent's digiti minimi and it will be seen lying in the hollow or concavity of the deep palmar arch. So you remember about deep palmar arch, which is formed by the deep branch of ulnar artery and completed by deep branch of radial or arteria princeps pollicis or arteria radialis indicis. It is present at a more higher level than the superficial palmar arch, the deep palmar arch. So it follows the concavity of the deep palmar arch and finally it ends by supplying the transverse head of adductor pollicis. So that is why the transverse head of adductor pollicis is also called as the graveyard of ulnar nerve. Okay, so mainly it supplies the three hypothenar muscles, then it also supplies the adductor pollicis muscle, then it supplies 4 palmar intraossei, then it supplies 4 dorsal intraossei and also medial 2 lumbricals, the deep branch. So almost it supplies around 16 muscles in the hand. So most of the intrinsic muscles except the first 2 lumbricals and the 3 thenar muscles, all the remaining muscles in the hand is actually supplied by the ulnar nerve. And it also gives articular branches to the wrist joint, intercarpal, metacarpophalangeal and carpometacarpal joints. So the sites of injury or the applied anatomy of the ulnar nerve you are able to see here. In the elbow, again the supracondylar fractures, it might get affected. Cubital tunnel syndrome. So cubital tunnel syndrome is again what happens is when there is an tendinous arch between the two heads of the flexor carpi ulnaris, origin of flexor carpi ulnaris, it forms a tunnel like structure which is called as the cubital tunnel. Sometimes arcade of Struthers, this is different from ligament of Struthers. Arcade of Struthers is again the deep fascia which gets thickened between your medial epicondyle and the olecranon process. Then injury at the level of wrist and also at the level of hand. So here you are able to see when there is a fracture even to the upper part of the ulnar bone or fracture involving the nervus sulci ulnaris in the elbow. So flexion of terminal phalanx is lost because of medial 1.5 fingers. The flexor digitorum profundus is not functioning. Okay. Then weak flexion and adduction of wrist because flexor carpi ulnaris is not functioning. So thereby weak flexion of adduction of wrist. Ulnar claw hand. So medial 2 fingers, they show the claw hand deformity, which is actually called as ulnar claw hand. Hypothenar muscles gets wasted and loss of adduction and abduction of all digits because below this level only it's going to supply most of the muscles. So naturally what happens is all the palmar interossei, all the dorsal interossei, medial 2 lumbricals are all paralyzed. So you don't have loss of adduction and abduction. Then loss of sensation of medial 1.5 fingers and skin over the hypothenar eminence. So all the structures supplied by the ulnar nerve will get affected if there is an injury to the ulnar nerve at the level of elbow or even at a higher level. Suppose if it is compressed in the cubital tunnel nerve entrapment, that is I told you between the 2 heads of the flexor carpi ulnaris. So symptoms same as we have told in the injury at the level of elbow takes place, but only difference is flexor carpi ulnaris and profundus is spared because it gives a branch before that itself. So there will be weakness of adduction of wrist, okay, and flexion of the terminal phalanx. Dorsal digital branch also will be spared, so no cutaneous loss over the dorsal aspect of the medial 1.5 fingers, but intrinsic muscles of the hand are paralyzed. Okay, so claw hand deformity, mainly if it is compressed in the Guyon's canal. I told you what is Guyon's canal. Paralysis of intrinsic muscles and loss of adduction of thumb because of adductor pollicis muscle, loss of abduction and adduction of all fingers because of the loss of innervation to the palmar interossei and the dorsal interossei. So ulnar claw hand, and what is ulnar paradox? Ulnar claw hand is, I told you, typical claw hand, medial 1.5 digits if it is affected. Ulnar paradox also, the higher the lesion to the ulnar nerve, the less pronounced will be the claw hand. Okay, because as you go higher, what happens is the flexor carpi ulnaris and the flexor digitorum profundus to some extent is actually not what do you call, they are not spared. So you get a very typical ulnar claw hand. So more higher the injury, the less pronounced is the ulnar claw hand deformity, which is actually called as the ulnar paradox. No loss of sensation again because the superficial branch it is given at a higher level, even the dorsal cutaneous branch is given at a higher level. So finally we come to the radial nerve, distribution of the radial nerve. It is actually from the posterior cord of the brachial plexus. So root value is going to be C5, C6, C7, C8 and T1, largest branch of the brachial plexus. Thickest nerve, thickest branch from the brachial plexus, mainly supplies completely posterior. Okay, so posterior compartment of arm, posterior compartment of forearm and dorsum of hand. For a brief period, it just comes to lie anteriorly in the region of cubital fossa. So in the axilla, it is seen behind the axillary artery and enters into the arm by the lower triangular space. So lower triangular space is formed by the above what you see is the teres major muscle, long head of triceps, and then the shaft of humerus along with the profunda brachii artery. It enters into the arm. So in the arm, it mainly supplies the triceps muscle, mainly the medial head and lateral head of triceps muscle. The branch to the long head of triceps muscle is again given at a higher level, and that is actually also called as the triceps escape. So here you are able to see in the arm, it pierces the lateral intermuscular septum and come to lie anteriorly for a short period. So in the cubital fossa, the lateral most structure will be your radial nerve. Okay, in front of the lateral epicondyle. So here it is also going to give some branches to the brachioradialis, extensor carpi radialis longus and extensor carpi radialis brevis. And immediately above the supinator, it will divide into a superficial and a deep branch. So branches at the back of arm, it supplies the triceps muscle and it also supplies the anconeus muscle. So the branch to anconeus also gives a branch to your elbow joint. Then posterior cutaneous nerve of the forearm, it is a cutaneous branch or the superficial branch. Front of arm, as I told you, it supplies brachioradialis, extensor carpi radialis longus and brevis. When it comes to the front of arm, in a very short period, in the region of the cubital fossa. So in the forearm, the superficial branch you are able to see here, and that is the deep branch. Before that, it gives the posterior cutaneous nerve of forearm in the lower part of arm itself. The superficial branch is a completely sensory nerve. It is present immediately deep to the deep fascia and ends by supplying the lateral 3.5 digits except the nail bed. The nail bed region of the lateral 3.5 digits, it's actually supplied by the median nerve. The deep branch of ulnar nerve is actually called as the posterior interosseous nerve. So winds around the radius and passes between the two planes of the supinator. It is present posterior to the posterior interosseous membrane along with the posterior interosseous artery, and finally it ends by supplying the wrist joint in the form of a pseudoganglion. So it shows a swelling just at its termination. It's a pseudoganglion because it does not have any nerve cell bodies, only the axon gets thickened. So all the extensor muscles, 7 superficial group of extensors and 12 deep group of extensors are all supplied by the deep branch of ulnar nerve, deep branch of radial nerve, which is actually called as the posterior interosseous nerve. So in the spiral groove or the radial groove, it might get affected. Then naturally what happens, the medial head mostly and the lateral head of the triceps lose its nerve supply, but the long head might retain its nerve supply. That is called as triceps escape. Wrist drop occurs because all the extensors of the forearm which are present in the forearm, extensor compartment muscles of the forearm, they get paralyzed. So the flexors become unopposed and pull the wrist to the front. So the wrist is flexed, that is called as wrist drop. Saturday night palsy is what happens is when you put your arm over the chair and you sleep overnight. So might be they tell Saturday night if you booze, people who booze because Sunday is a holiday or something like that. When you sleep by the arm hanging by the side in the chair, what happens is the posterior cord of the brachial plexus or your ulnar nerve might get compressed. That is called as Saturday night palsy. Crutch palsy, so people who cannot walk, who have poliomyelitis or something, they use crutches as a support. So this crutch might again put undue pressure onto your radial nerve. So naturally paralysis of the radial nerve takes place, of the muscles of the extensors takes place, leading to the wrist drop and other symptoms, that is loss of cutaneous sensation over the posterior compartment of arm and also your dorsum of the hand, lateral 3.5 digits. Okay. So due to wrist drop, there will be loss of extension of fingers, thumb and wrist. So with this, we have completed summarizing the origin, course, branches and applied anatomy of the median nerve, radial nerve and the ulnar nerve. Thank you very much for your patient listening.